Hi, everyone. Today, we're diving into the topic of acute liver failure in dogs and cats. Specifically, we'll explore some controversial topics, including the differences in acute liver failure definitions between human and veterinary medicine, the challenges of performing liver biopsy in coagulopathic patients, and lesser known but important differential diagnoses such as pregnancy associated acute liver failure, which is well documented in humans but not yet widely recognized in veterinary medicine. Let's dive in. The 2023 American Journal of Gastroenterology Human Clinical Guidelines outline three key criteria for diagnosing acute liver failure, or ALF. Absence of pre-existing liver disease, presence of coagulopathy, typically defined as an INR greater than 1.5, and any degree of hepatic encephalopathy. Now, let's pause for a second and talk about PT versus INR because they come up a lot in liver failure. First, INR and PT are both measures of clotting, but they specifically reflect the extrinsic and common coagulation pathways, which include several clotting factors made by the liver. That's why they're preferred over PTT when evaluating liver synthetic function. Now, here's the catch. PT, or prothrombin time results, can vary depending on the reagents used by each lab. That's where the INR, or International Normalized Ratio, comes in. It standardizes PT across labs and makes it possible to compare values accurately. Historically, INR has been more commonly used in human medicine, while PT is more frequently used in veterinary practice for assessing coagulation and liver function. In liver failure, a rising INR, or PT, reflects worsening liver synthetic function, which is why it's part of the ALF definition in human guidelines. Unfortunately, in dogs and cats, we don't have standardized criteria for ALF diagnosis. The landmark Lester et al. 2016 study, the largest retrospective study on canine ALF to date, included 49 dogs and defined ALF as acute clinical signs with concurrent hyperbilirubinemia and coagulopathy, with PT greater than 1.5 times the upper reference limit. But here's what's missing in this definition: encephalopathy. The authors explicitly state, considering the difficulty in retrospectively assigning the presence of diffuse cerebral signs suggestive of hepatic encephalopathy, we did not include encephalopathy in our definition. That makes sense. Early stage hepatic encephalopathy is a neuropsychiatric syndrome, and it can be very hard to recognize in animals or in very young children who can't describe symptoms. For example, in adult humans, grade 1 or mild form of hepatic encephalopathy may involve the following clinical signs: mild lack of awareness, shortened attention span, difficulty with simple math, and altered sleep rhythms. Obviously, these are not reliably detectable in veterinary patients. So, while encephalopathy may be hard to detect in every single veterinary patient with suspected acute liver failure, we still try to assess for altered mentation and neurologic changes when possible. It's also important to separate acute liver injury, or ALI, from acute liver failure, or ALF. Acute liver injury means hepatocellular damage, usually with elevated liver enzymes, but preserved liver function. Acute liver failure, on the other hand, involves functional hepatic failure, impaired coagulation, glucose metabolism, protein synthesis, etc. The presence of coagulopathy and encephalopathy typically marks the tipping point from injury to failure. Now that we've reviewed the diagnostic framework, let's look at common causes of ALF in humans and animals. According to the 2023 human guidelines, the most common causes in humans include the following: acetaminophen toxicity, drug-induced liver injury or DILI, often secondary to idiosyncratic drug reactions other than acetaminophen, viral hepatitis, and so-called cryptogenic ALF, where no cause is identified. In dogs, the Leicester 2016 study found that an etiology could be determined in about 1/3 of cases. The most common cause was neoplasia, diagnosed in 13 dogs, including 8 with hepatic lymphoma, 2 with undifferentiated round cell tumors, and others with mast cell tumors, epithelial carcinoma, or metastatic disease. Interestingly, lymphoma was diagnosed in 2 dogs from aspirates of grossly normal popliteal lymph nodes. Leptospirosis was suspected in 4 dogs with acute liver failure based on initial titers, although only 1 dog survived long enough to confirm it by convalescent titers. Even though titers weren't run in all dogs, this study highlights that leptospirosis can cause ALF, sometimes without renal involvement. Therefore, empiric treatment with a penicillin class antibiotic and lepto testing should be considered in dogs with ALF until ruled out. In the group without a definitive diagnosis, 15 dogs had known exposure to potentially hepatotoxic agents, including NSAIDs in 7 dogs, phenobarbital, sulfonamide, doxycycline, cephalexin, equine glucosamine, and mushrooms. While dogs and cats can share many underlying causes of acute liver failure, cats may also develop ALF from species-specific conditions, such as hepatic lipidosis and infectious diseases like feline infectious peritonitis and toxoplasmosis. Also, they are more sensitive to acetaminophen toxicity. In people, they also recognize pregnancy-associated liver diseases as potential causes of ALF that may even require a liver transplant. While we don't have documented veterinary cases, I've personally seen dogs in late pregnancy or postpartum develop ALF with no other obvious cause. In humans, there are 2 major pregnancy-related syndromes that can lead to acute liver failure. The first is HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. The second is acute fatty liver of pregnancy, or AFLP. Both usually show up in the 3rd trimester. HELP is believed to be driven by complement-mediated systemic inflammation. The cornerstone of treatment is prompt delivery, but in severe cases, liver transplantation may still be necessary. Another important differential to consider is acute exacerbation of copper storage disease, known in humans as Wilson's disease. Copper is an essential nutrient, but in copper storage disease, it accumulates in the liver due to increased consumption, abnormal storage, or impaired excretion, causing tissue damage. In both humans and dogs with acute liver failure secondary to copper storage disease, acute hepatocellular necrosis may cause release of large amounts of stored copper from the damaged hepatocytes. Unbound copper in the plasma can cause oxidative damage to the red blood cell membrane, leading to hemolytic anemia. Therefore, unlike chronic copper hepatopathy, Acute copper toxicity can be diagnosed by an elevated serum and urinary copper, as well as hepatic copper accumulation seen on biopsy. So, you may consider measuring serum copper levels or performing hepatic copper staining on liver samples in select dogs with acute liver failure that may be predisposed to copper storage disease, such as Bedlington Terriers, West Highland White Terriers, Skye Terriers, Dalmatians, Doberman Pinschers, Labrador Retrievers, and Kern Terriers. In humans and dogs, the prognosis of Wilson's disease-associated acute liver failure is poor without liver transplantation. Chelators like D-penicillamine are ineffective during acute decompensation. In people, temporary measures like plasmapheresis or albumin dialysis can reduce copper burden but are not definitive. All right, now let's talk about the role of liver biopsy in patients with acute liver failure. By definition, ALF patients are coagulopathic. So, should we even attempt a biopsy? In human medicine, liver biopsy can rule out infiltrative disease or malignancy. It can also diagnose autoimmune hepatitis, which may respond to steroids. Finally, it can identify contraindications to transplantation. Their preferred technique is transjugular liver biopsy, or TJLB, because it avoids puncturing the liver capsule and minimizes bleeding risk. Sounds great, right? But here's the problem in veterinary medicine. Back in 2014, a study published in JVIM by Levine et al. Looked at whether transjugular liver biopsy could be used safely in dogs. They tested it in 25 canine cadavers, and the results weren't great. 64% of the dogs had major complications, and in over 80% of those cases, the liver capsule was perforated. So the authors concluded that because of the way canine liver lobes are shaped, transjugular biopsy just isn't safe in dogs. And it's not recommended in clinical practice at this point in time until more research is conducted. So if transjugular biopsy isn't safe in dogs, what options do we have left? Another option is a mini laparotomy with biopsy. A 2014 human study by Deschênes et al. Looked at 39 patients with ALF and high INRs who underwent mini-lap biopsies, and they found no major complications with this approach. That said, the patients in that study had mean INR values approximately 1.8 times above the reference limit. So you need to be cautious when applying those findings to the patient in front of you. For example, if you're managing a patient whose PT is too high to read and whose fibrinogen level is below 50 milligram per deciliter, the risk of bleeding is likely much higher than in a patient with only mild to moderate PT elevation, say 1.8 times the upper reference limit. Another readily available option is a fine needle aspirate, or FNA. This is especially useful when you're trying to rule out infiltrative diseases like hepatic lymphoma. And that's an important point. Missing a diagnosis like lymphoma could be a big deal. In some cases, the diagnostic value may outweigh the bleeding risk. Now, let's circle back to Lester's canine study. Overall, 32 out of 49 dogs, about 65%, had their liver tissue evaluated either by aspirate, biopsy, or necropsy. Of those, 11 dogs had liver biopsies while still alive, and 6 underwent fine needle aspiration. The most common liver lesion was necrosis, seen in nearly half the cases. Hepatic degenerative changes like lipidosis were present in 40% of cases, and vacuolar changes in about 19%. neoplasia was diagnosed in 13 out of 32 dogs. That's 40%, which is a lot. Acute hepatitis with inflammatory changes was seen in 21% of cases. So, should you biopsy a patient with acute liver failure who is inherently coagulopathic? In my opinion, it's all about weighing the risks and benefits, especially if you are trying to rule out infiltrative neoplastic disease. Now, before we wrap up, let me walk you through how I approach coagulation testing in ALF patients before biopsy. According to the 2023 human guidelines, the INR does not accurately reflect bleeding risk in patients with ALF. Viscoelastic tests may provide a more accurate assessment of coagulopathy in patients with ALF. They also recommend against correcting coagulopathy unless the patient is actively bleeding or about to undergo an invasive procedure. So here's what I typically check before considering liver biopsy: PCV and total solids, platelet count, blood type and a cross match if indicated, PT, PTT, and fibrinogen levels, and finally, viscoelastic testing. I personally have access to the VCM vet test. This gives me a more complete picture of the patient's coagulation status and may also reveal hyperfibrinolysis, which I can treat before biopsy with aminocaproic or tranexamic acid. Another important benefit of viscoelastic testing is that it assesses the global hemostatic ability of the patient with acute liver failure. This is particularly useful because standard coagulation tests like PT, PGT, and platelet count often provide an incomplete or misleading picture. In liver failure, both procoagulant and anticoagulant factors are reduced, creating a state of rebalanced hemostasis that is not accurately captured by traditional assays. For example, despite markedly prolonged PT, some ALF patients may not actually be at increased bleeding risk, and in fact, may even be at risk of thrombosis. Viscoelastic tests, such as VCMTG or ROTAM, can identify hypercoagulable, normocoagulable, or hypocoagulable states in real time, allowing for more precise transfusion and anticoagulation decisions. So in my practice, if the PT and or PTT are significantly elevated, such as greater than 50% above the upper reference limit, especially in combination with hypocoagulable viscoelastic tracing, I'll consider giving fresh frozen plasma at 10 to 20 ml per kg about 4 to 8 hours before the liver biopsy procedure. If fibrinogen or factor 1, which is almost exclusively produced in the liver, is below 100 milligram per deciliter, I will also try to correct it before an invasive procedure, because low fibrinogen has been associated with spontaneous bleeding in people. Fibrinogen levels can be replenished by fresh frozen plasma or cryoprecipitate transfusion. However, cryoprecipitate may be costly and less readily available, especially in larger dogs where higher volumes are needed to achieve therapeutic levels. But just to be clear, plasma is only indicated if the patient is bleeding or you're preparing for something invasive, like a liver biopsy. All right, let's wrap up with 5 practical takeaways you can use in the ER today. Number 1, you don't need obvious encephalopathy to suspect acute liver failure. If you see high ALT, hyperbilirubinemia, and a PT over 1.5 times normal, ALF should be on your list, even if the patient's mentation seems relatively normal. Measuring ammonia levels in patients with suspected acute liver failure but relatively normal mentation may help increase your sensitivity in detecting early or subclinical hepatic encephalopathy. So remember, encephalopathy can be subtle or hard to detect in animals. Number 2, if you're dealing with a dog with suspected ALF, get a complete medication and supplement history, including over-the-counter meds that owners could have given to that patient. Things like NSAIDs, phenobarbital, sulfa drugs, doxycycline, and even glucosamine have all been linked to liver failure in dogs. Number 3, if you're seeing a late pregnancy or postpartum dog with sudden liver failure, don't rule out pregnancy-associated ALF. We don't have published cases in veterinary medicine yet, but in people, it's well documented, and I've seen a couple of suspected cases. Number 4, don't rely on PT alone to assess bleeding risk. If you can, run viscoelastic testing and check fibrinogen level. Only give plasma if the patient is actively bleeding or about to undergo a high-risk procedure like a liver biopsy. And number 5, hepatic lymphoma or other infiltrative disease is an important differential in ALF. Often, a fine needle aspirate is enough to rule it out, but in some cases, a mini lab biopsy may be necessary. All right, that's it for today. In future videos, we'll dive into more hot topics, like whether N-acetylcysteine and vitamin K are truly evidence-based treatments for patients with acute liver failure. Thanks for watching, and I'll see you next time. Bye-bye.